11 o'clock.
Good morning, everyone. The topic for today's seminar is TB-HIV molecular interplay. I am Dr. Monica Sinha and my moderator is Professor Dr. Urvashi ma'am. So I will be talking about this topic under the following headings. First, we'll discuss about the TB-HIV co-infection impact on the global world. Then we'll look into the current data, followed by the status of this co-infection in our setting. After that, we'll discuss about the spectrums of outcome following the exposure of tuberculosis infection. Then we'll discuss about the immune spectrum in TB as well as in HIV. After that, we'll discuss the pathogenesis of the LTBI and its reactivation, followed by the effect of HIV-induced immunosuppression on MTB and vice versa. Then we'll discuss about the phenomenon immune reconstitution inflammatory syndrome, followed by the diagnosis of TB and HIV co-infected person. And at last, we'll discuss about the management and the strategies for prevention of this linked epidemic. Before going into the topic proper, we must understand why this TB-HIV co-infection is posing a great challenge today. As we know that now today we have a very good treatment available for HIV, such that the life expectancy of people living with HIV is almost similar to that of without HIV. However, this deadly synergy between these two pathogens is causing a great challenge in control of both these two diseases. So now people are living with HIV, but they are dying because of this TB infection. This mainly happens because of the immunosuppression induced by the HIV, which increases the risk of tuberculosis infection in these patients. It not only increases the risk of tuberculosis in these patients, but it also makes the prognosis worse, as well as the progression is also very rapid. We can see here that if we see the worldwide data, the TB is the leading cause of death among the patients living with HIV, such that almost every third death because of AIDS is due to the tuberculosis infection. This high incidence of mortality is because of the interaction between these two pathogens, which causes a reciprocal advantage to both the pathogens. Also, there is a rise in the drug resistance cases, which not only prolong the already longer duration of treatment, but also decreases the treatment success rate. The highest burden of this co-infection is seen in the sub-Saharan Africa, which contribute to around 71% of the cases. Our country, India, ranks second in position, contributing around 92,000 cases of TB cases among the people living with HIV. So this is the picture which I have taken from the WHO. It shows the top 30 high most TB HIV burden countries. Here we can see that these countries are China, India, Indonesia, Kenya, Myanmar, Nigeria, and these countries not only have this co-infection burden, but they also have the MDR-TB burden, which makes the condition more worse. Coming to the statistics which recorded in the 2019, it shows that the total number of estimated patients living with the HIV is around 38 million, while total new HIV infection was estimated to be around 1.7 million. The total new TB cases was found to be around 10 million, while the total new cases of MDR-TB was found to be around 206,030. If we see the mortality data, the death due to the TB-HIV co-infection was found to be around 251,000, while because of TB alone it was around 12 lakhs, and because of HIV alone it was around 7,70,000. This is the graph showing the number of people dead per year from the year 2000 to 2017. The blue color is showing the number of TB death among the HIV negative people, while this red color is showing the number of TB death among the people living with HIV. So as we see that there has been a decline, around 53% of decline in the number of TB death among people living with HIV, but we must not forget that it is still one of the leading cause of death among these patients. Coming to the Indian scenario, so in India, the HIV-TB co-infection is increasing. Almost around 25% of death among the patient living with HIV is because of the tuberculosis infection. According to the data, it has shown that almost 3% of TB patients who registered under the RNTCP also have HIV infection. The isoniazid preventive treatment coverage was found to be only around 43% in the people living with HIV. This shows that almost more than half of the people are still susceptible to tuberculosis infection. And while in India, every year around 11,000 deaths has been recorded due to this TB-HIV co-infection. So this is the data which I have taken from the India TB report 29 published on September 2019. It shows that the co-infection rate is been increasing in India from 3% to 3.4%. Also, if we look at the different TB-HIV burden in our different states, we'll find that Nagaland ranks first, contributing around 15.6%, followed by Karnataka, Chandigarh, and Manipur. The treatment success rate has also seen a decline from the year 2019, where it was 79%, and now in 2019 it has become 70%. The failure of treatment success rate, as I've told, this could be because of the increase in the drug resistant cases in India. So while our country is dealing effectively with this HIV-TB burden, the TB-associated HIV epidemic is posing a great challenge for us. These are some of the facts related to TB and HIV co-infection. The patient living with latent TB infections are almost 19 times more likely to develop active TB. And if this co-infection is a synergic, interactive, and giving a reciprocal advantage and with a significant impact. So this is the graph which shows the annual trend of TB-HIV burden for India from the year 2001 to 2017. It shows that the number of death due to TB and HIV patient has declined, and but still it's been a leading cause of deaths. And now the recent data is showing that it has been increased also. It's been increasing. So this is the timeline of HIV and TB infection. So the first case for the association between TB and HIV among the people with AIDS was recorded in 1983. In 1988, WHO first recommended a joint approach for tackling this TB-HIV infection. In 1986, the first report of high HIV prevalence among the people with TB in Africa was noted. In 1995, the data shows that the people living with HIV with active TB have higher viral loads and they die sooner compared to the people without TB. In 2003, it was estimated that the 3% of people with TB were tested for HIV. In 2005, the Malawi uses a model for delivering antiretroviral therapy based on the TB model, incorporating the DOTS principle. In 2006, the WHO called an urgent meeting to discuss the outbreak of an extensively drug-resistant TB among the people living with HIV in South Africa. In 2009, there was a new WHO guideline which recommended that every patient living with HIV should receive antiretroviral therapy regardless of their CD4 count. In 2016, several recommendations were made by WHO to speed up the detection and improve the treatment outcome in the MDR-resistant TB and by using rapid diagnostic tests which are shorter, cheaper. In 2016, the United Nations Declaration on Ending AIDS includes the work towards the target against reducing the TB-related death among people living with HIV by 75%. In 2017, for the first time, the number of people living with HIV assessing the treatment exceeds the number of people not on treatment. In 2018, the United Nations General Assembly adopted a political declaration on fight against the TB. So now coming to the spectrum of outcome following the exposure of Mycobacterium tuberculosis. So as we know that after an exposure to Mycobacterium tuberculosis infection, the infection may fail to establish an infection due to the effective innate immune response or if the bacilli fail to reach the lung alveoli. In case of established infection, there will be a lymphatic as well as hematogenous spread, which will be controlled by the cell-mediated immune response, which is evidence in form of TST or IGRA positivity following 4 to 8 weeks after exposure. In case of immunocompromised host, however, in case of an immunocompromised host, there will be a progression of this disease as the bacillary replication will not be they will not be able to control the bacillary replication. So here these solid line are showing the usual route of progression, while the dashed line are showing the unusual route of progression. The red line is showing the progression in case of an immunocompromised host, while the blue line is showing the progression in case of immunocompetent host. So here we can see in case of immunocompromised host, the route of progression is mainly to either to the localized extrapulmonary TB, disseminated TB, or a non-cavitary pulmonary TB. While in case of immunocompetent host, it is mostly to the cavitary pulmonary TB. This is because of the fact in case of HIV there is reduced CD4 count and hence there is less cavitation formation leading to the non-cavitary lesions. While also the cavitation in case of immunocompetent hosts increases provide an environment for increased bacillary replication, which also increases the risk of transmission. While these immunocompromised patients, there is a less risk of transmission. Coming to the immune spectrum in tuberculosis, so this Mycobacterium tuberculosis important feature is that it has the ability to subvert and survive the protective host response. The host response in Mycobacterium tuberculosis is multifaceted with several critical stages. Broadly speaking, these are initial innate immune response, granulomatous response to infection coinciding with the adaptive immune response, and third is the host response to failure of the granuloma formation. The HIV-co-infection affect each of these stages, influencing both the likelihood of the diseases as well as the nature of presentation. We'll just briefly discuss the immune spectrum in case of tuberculosis. As we know that after the inhalation of inhaled bacilli, these bacilli are first phagocytosed by the resident alveolar macrophages as well as the dendritic cells. the infected host cells release cytokines as well as chemokines, which causes migration of the dendritic cells to the local lymph nodes, leading to the recruitment of the T lymphocytes. This T lymphocytes are critical for the host defense against the Mycobacterium TB. They are the source of interleukin 2 as well as interferon gamma, which helps in the killing of the infected macrophages and lysing the Mycobacterium TB bacilli. Now we'll discuss each of these immune-mediated response in detail. The first was the innate immune response, that was the macrophage-mediated immune response. So as we know that these are phagocytosed by the resident alveolar macrophages and the tissue dendritic cells. Now almost 40 to 70% of these infected individuals will be able to eliminate this Mycobacterium tuberculosis only by the mechanism of this innate immunity. But during the early stage of infection, these macrophages dominate this immune response. The establishment of the infection depends on the ability of mycobacteria to survive within the host. So the macrophage mediates its immune response by the following method. First is the autophagy, then is the efferocytosis, then the reactive oxygen by releasing reactive oxygen species, and by releasing vitamin D and antimicrobial peptides. We'll discuss each of them in detail. So coming to the first mechanism by which the macrophage mediates its immune response, that is the autophagy. So this autophagy is a highly confined process which leads to degradation of the proteins as well as cellular organelle. So as well as the cellular organism. So in this picture, we can see that this autophagy phenomenon is being done by formation of a double membrane structure known as autophagosome. This autophagosome then fuses with the lysosome, and which will finally lead to the killing of the Mycobacterium tuberculosis. So so after the MTB infection, the bacilli is carried to this delivered to this autophagosome by the STING, that is stimulator of immune interferon gamma gene, which flags these bacilli with ubiquitin, and they are delivered to this autophagosome. This autophagosome have receptor to recognize this ubiquitin, and then after that they fuses with the lysosome, and which will leads to the killing of the Mycobacterium TB. So what causes this induction of the autophagy? These are toll-like receptors, ATPase, vitamin D, reactive oxygen species, interferon gamma, and CD4 T ligand. And what causes the inhibition of this autophagy are this protein kinase G, the coronin 1 expression by the MTB, etc. Coming to the second mechanism, that is efferocytosis. So this efferocytosis has been derived from a Greek word meaning to take to the grave. So this efferocytosis is basically the engulfment and the degradation of the apoptotic bodies by the macrophages. So after the initial infection with the Mycobacterium tuberculosis, there is induction of apoptosis, and these apoptotic infected macrophages are recognized by the bystander uninfected macrophages, and they are then delivered to the lysosomes. Also, there is also expression of the human neutrophil peptide 1 protein, which enters the uninfected macrophage by the process of efferocytosis and help in the killing of this Mycobacterium tuberculosis. The Mycobacterium TB antigen generated are then put for cross presentation, which help in priming of the CD8 T cells. Coming to the next mechanism, that is reactive oxygen species. So this reactive oxygen species are toxic to the Mycobacterium, and they cause they work against the Mycobacterium TB by following autophagosome formation, by causing apoptosis as well as necroptosis. So in this the interferon gamma secreted, it causes the induction of GTPase, which delivers the NOx2 subunit to the phagosomal membrane. These after the accumulation of the cytosolic NOx2 subunit as well as the membrane NOx2 subunit, it leads to the generation of reactive oxygen species. Now, this reactive oxygen species is toxic to the mycobacterium, leading to the killing of this intracellular bacilli. Also, the TNF causes the aberrant release of mitochondrial release of the reactive oxygen species, which can cause autophagosome formation and finally leading to autophagy or apoptosis or necroptosis. The next mechanism is by vitamin D and antimicrobial peptide. So this vitamin D helps in the phagocytic pathway of the macrophages. So after the entry of vitamin D, it catalyzes the conversion of 25-dihydroxyvitamin D to bioactive 125-dihydroxyvitamin D. So this bioactive molecule then binds with the vitamin D receptors and causes the expression of the antimicrobial peptide and the cathelicidine, which will finally leads to the formation of autophagosomes and lead to the death of the Mycobacterium TB bacilli. So now, how these Mycobacterium tuberculosis is able to avoid this all immune mechanism, that is autophagy, efferocytosis, and reactive oxygen species production. So in case of autophagy, the Mycobacterium species produces a protein that is the extracellular survival protein, which inhibits the autophagy. It also secretes a protein kinase G protein, which prevents the phagosome formation. In case of efferocytosis, it modulates the both and pro-apoptotic as well as the anti-apoptotic pathway, leading to induction of the anti-apoptotic proteins such as MCL1 and inhibition of the apoptotic proteins. In case of reactive oxygen species, the nicotinamide, the kinase inactivates the GTPase, leading to inhibition of the NOx2 assembly. Hence, the NOx2 assembly is not being formed, and hence the ROS production is inhibited, and hence there will be no an autophagy or necroptosis or the apoptosis of the Mycobacterium TB. Coming to the second type of immune response, that is the granulomatous response to infection. So effective cell-mediated immune response to Mycobacterium TB results in the granuloma formation and control of the bacillary replication. These granulomas are actually the lymphocytes rim surrounding the macrophages, which are differentiated into epithelioid cells and the Langerhans giant cells. The central calcium is derived from the necrotic cellular debris. So it is measured by this cell-mediated immune by positive TST or interferon gamma release assay. Now coming to the immune response in HIV. So the immune, as we know that both adaptive as well as innate immune mechanism play an important role in control of the HIV infection. However, we will focus our discussion here only on the T cell response, as they are the mainly affected in the HIV-TB co-infection. So we know that the HIV binds to its CD4 receptor along with the chemokine receptors CXCR4 and CCR5. After this binding, these T cells are important for orchestrating the activation of the adaptive immunity, such as B cells and the CD8 T cells, and hence this HIV impairs the immune response against the virus itself. So the main effect of HIV we already know is causing the leading to causing the dysfunction of the CD4 T cells, leading to depletion as well as the exhaustion of the CD4 T cells. Here in this picture, we can see that the viral replication causes the decrease in the MHC class 1 binding and decrease in the T cell receptor recognition and decrease apoptotic processing, leading to insufficient CD8 T cell response, which will lead to chronic infection and repeated T cell activation, which will finally leads to T cell exhaustion due to the continuous antigen presentation. And there is also, in case of CD4 T cell, it causes the apoptosis of these cells, leading to immunodeficiency and decrease in the T cell functions. Now coming to the pathogenesis of HIV and TB co-infection. So as we know that it is a bidirectional interaction. The HIV alters the course of MTB and also increases the risk of active TB, while MTB increases the level of HIV replications, its propagation, as well as genetic diversity. So this co-infection provides a reciprocal advantage to both these pathogens. So this is the picture showing the different ways by which HIV alters the immune response against the mycobacterium TB. So first one is that it alters the macrophage phagocytic activity, it affects the cytokine secretion, it interferes with the processing and presentation of MTB antigen, it depletes the CD4 cells, it disturbs the T helper subsets balance towards a more inflammatory profile, it inhibits the apoptosis, and it also promotes systemic hyperinflammation. We'll discuss each of them in detail. So first is how HIV alters the macrophage phagocytic and autolytic activity. So as we know, this HIV secretes a non-structured protein, that is the negative regulatory factor protein, which causes which inhibits the endosomal recycling formation of the new phagosomes. As a result of this, there is an increase as a result of this, there is increase in the nascent phagosome which are immature. Also, this HIV NEF protein also causes the inhibits the fusion of this autophagosome with the lysosomes by inhibiting the Backlink-1 protein. The end result is that there is a decrease in the autophagy clearance of MTB, as well as there is decrease in the autophagy clearance of the HIV because of the either there is a failure of maturation of autophagosome, or there is failure of fusion of autophagosome with the lysosomes. Also, it has been seen that the vitamin D supplementation in these cases has overcome this inhibition and maturation and improves the MTB clearance and the HIV restriction by autophagy. Coming to the next mechanism by which the HIV interferes is with the with the dendritic cell and the T cell axis. So this is the model which explains why there is this MTB infected CD4 T cells causes a decrease in immunosuppression as well as increase in the TB risk. So first, if we compare to the singly infected MTB dendritic cells, the MTB HIV infected dendritic cells, there is a decrease in the expression of the stimulatory molecules as well as the activation markers. Also, this doubly infected MTB and HIV dendritic cells alters the balance between the co-stimulatory molecule, causing decrease in their expression, and increase the co-inhibitory molecule, causing an increase in their expression. The end result of all this is that the MTB specific CD4 T cells are unable to they lose their control in the controlling the MTB infection, and also they, increases the growth of these bacilli. This bacilli. Coming to the HIV, how HIV affects the cytokine secretion. So as we know that the interferon gamma plays a pivotal role in signaling of immune system during the replication. So it has been seen that there has been reduced production of this interferon gamma and its cellular receptor, leading to the severe and fatal TB infection. During this HIV infection, this interferon gamma production is decreased, which leads to the increased risk of developing reactivation as well as the reinfection in case of HIV patients. So, next is the HIV. It causes inhibition of the apoptosis. So as we know, this NEF protein inhibits the apoptosis by reducing the TNF alpha production, and it also manipulates the apoptosis by regulating the pro and anti-apoptotic protein. The viral protein GP120, viral protein unique, the viral protein R and protease inhibits the apoptosis and promotes the viral replication. So next mechanism is the HIV also interferes with the processing as well as the presentation of Mycobacterium TB antigen. It causes the down modulation of the surface expression of CD80 and CD86 on the APC through its NEF protein. NEF is also shown to promote the expression of immature functionally incompetent MHC class II complexes. It also inhibits the upregulation of CD40 ligand on T cell and CD80 on the APC through GP120, thus inhibiting the T cells activation. Thus, and we have already seen that the HIV-infected dendritic cells have reduced ability to upregulate the key co-stimulatory molecule, and hence which are critical for the antigen presentation in presence of Mycobacterium TB infection. So next is the HIV, how it disturbs the T helper subsets balance towards a more inflammatory profile. So as we know that the T helper cells predominant response is important for the protective immunity, while the T helper 2 response is important, and the T regulatory cells are leads to the severe and disseminated disease. So, so this balance of this T helper cell and T helper 1 cells and T helper 2 cells and T regulatory cells is important in many infections. This balance is being this balance is being disturbed by many infections such as chronic infections such as CMV, hepatitis B and C, HIV, in case of severe infections such as malaria and measles. In case of HIV, there is decrease in the T helper 1 response and also decrease in the interferon gamma response, which will lead to increased pathogenesis and increased risk of infection disease and also leading to severe disseminated TB disease. Not only this, it also causes the decrease in the ratio of T regulatory gene as well as the T helper 17 cells. So, T regulatory cells as well as the T helper 17 cells. So, as we know that T helper 17 cells are mainly involved in the inflammatory reaction by the recruitment of the neutrophil causing the lysis of the bacteria, while the T regulatory cells are mainly involved in the autoimmunity. So this ratio, in case of AIDS and TB co-infection, it has been found that this ratio is found to be decreased, which leads to the progression of this disease. Not only progression, it also increases the HIV replication and finally leading to the aggravation of AIDS with TB infection. So this is the study published in 2017, which showed that which shows the effect of the T helper 17 and T regulatory cells imbalance on HIV replication in patients with AIDS. So here they took around 32 patients with AIDS and 30 healthy individuals, and then they measure their peripheral T lymphocyte by using flow cytometry, and they found that initially the T helper 17 was decreasing, but later it increased. While in case of T regulatory cells, they followed the increased trend. So this study find that this this increase in the ratio promotes the HIV replication in AIDS patients with TB infection. So the one of the main hallmark of this HIV is that it depletes the CD4 T cell count. So in case of MTB, not only this, they depletes mainly the M tuberculosis specific CD4 T cell count, and this is the reason why patients with even normal or restored CD4 T cell count, they are still susceptible to increased risk of TB infection. This MTB specific CD4 T cells count played an important role in efficient control of TB infection and hence further dissemination to extrapulmonary site. So in case of early infection, the MTB specific CD4 T cell causes, studies have seen that there has been depletion of this MTB specific CD4 T cell both from periphery as well from the disease site. Also these MTB specific CD4 T cells shows increased high level of expression of HIV co-receptor, that is the CCR5. It also shows production of interleukin 2, and however there is no MIP-1 beta production. The lack of macrophage inflammatory protein 1 beta increases this susceptibility to HIV infection and the subsequent depletion. Also as I have already told that this MTB specific CD4 T cell shows a high expression of CCR5 receptor. They become the potential target for the HIV infection. So we can say that the HIV co-infection promotes a microenvironment which facilitates both HIV replication as well as MTB specific CD4 T cells depletion. while the T regulatory cells exerts an opposite effect depending on the active TB state. In case of active infection, they delay the onset of adaptive response. In case of chronic infection, there is resolution of TB by preventing the inflammation-mediated tissue damage. So, also as we have seen that this interleukin 2 are important for the T cell proliferation and the expansion of MTB specific T cells. This proportion of CD4 T cells producing interleukin 2 is inversely associated with the HIV viremia and HIV infected person with LTBI. The hyperresponsiveness of this MTB specific CD4 T cells leads to the dysregulation of the interferon gamma as well as interleukin 2 axis in macrophage and monocytes. So, in short, we can say that during an early phase of HIV infection, when the CD4 T cells count is maintained, there is sustained systemic infection and there is a suboptimal T helper type of CD4 response, and hence there is a poor Mycobacterium tuberculosis control. While in case of advanced phase of HIV, there will be a reduction in the number of CD4 T cells count, and hence because of this there is an increased risk of tuberculosis. Also, the HIV infection impacts. Also there is an impact of HIV infection on Mycobacterium TB specific CD8 T cell response. So, as we know that Mycobacterium TB antigen processed by the cytosolic pathway are presented by the MSC1, which elicits the CD8 T cell response. This CD8 T cell response are present in the granulomas of the infected person, and they secrete interleukin 2 and interferon gamma as well as the TNF alpha. They also express perforin and granulolysin, which kills the Mycobacterium TB infected macrophages. In case of HIV infected person, there has been a decreased expression of the degranulation marker, that is the CD107A, which causes diminished CD4 T cell response and hence leads to the impaired proliferative capacity as well as the cytotoxic function in the CD8 T cells. Now, coming to the impact of HIV on the tuberculosis granuloma formation. So, as we know that in case of effective cell-mediated immune response, there is a granuloma formation and hence containment of the MTB infection. In case of HIV, we know that there is a decrease in the CD4 T cell count and hence the granuloma structure is altered. So, in case of early infection, there will be a decrease in CD4 there will be a decrease in the CD4 T cell only at the peripheral site, and there will also be a decrease in CD4 and CD8 ratio. As there is further progression, there will be decreased macrophage activation and the decrease in epithelioid cells as well as the decrease in the Langerhans cells, which will further derange the structure of the granuloma. While in case of the advanced disease, there will be increased necrosis and increase in the neutrophil as well as the increase in the Mycobacterium TB bacilli. During this response, there will be the TST response will either be reduced or it might be absent. So, here we can see that the HIV progression is not only affecting the granuloma, but it will also affect the presentation of the disease. Since we know that in HIV there is an immunosuppression and there is a reduction in the CD4 T cell count, there will be a decrease in the cavitation formation and hence the presentation will be mostly atypical. The initiation of ART in case of early phase will help in the enhancing the immune response and hence can reduce the disease progression. While in case of advanced disease, due to the high MTB bacillary load, it can lead to a syndrome known as immune reconstitution inflammatory syndrome. Now, coming to the we'll discuss about the effect of MTB on the HIV. So first, it causes an increase in the HIV replication. So this MTB infection causes deleterious effects on the host control of the HIV infection. So basically, it works by three mechanisms. First is the innate immune signaling pathway. Second is the pro-inflammatory cytokine, and third is the failure of immunoregulation. So this is a picture showing the effect of MTB on HIV replication. So the MTB, it causes reduction in the transcription factor and hence reducing the HIV transcription. Not only this, because of the infected host cells, they will release many chemokines as well as cytokines, which will leads to the recruitment of the T cells, and these T cells are permissive to the HIV, and hence there will be cell-to-cell spread. The interleukin, the MTB also inhibits the interleukin-2, which are also responsible for the increase in the transcription factor of HIV. Studies have shown that MTB also increases the polyploidy in the macrophages. Also increases the polyploidy in the macrophages. So next, coming to the effect of MTB on HIV is the in its tropism and the diversity. So it has been found that there has been twofold higher CXCR4 mRNA level in the bowel fluid. So this increased expression of CXCR4 compared to the CCR5 on alveolar macrophages leads to enhancement of the CXCR4 tropic HIV complementary DNA production and hence selection of the X4 tropic HIV virus. It has studies have also shown that there have been increased mutation frequency by almost 2 to 3 fold because of the MTB infection. Now coming to the important phenomenon, that is the tuberculosis inflammatory reconstitution inflammatory syndrome. As we know that the because of the initiation of RT, we are able to control many of the co-infection, including the tuberculosis. However, the ART initiation can trigger a pathological hyperinflammatory response to viable or dead Mycobacterium tuberculosis. As we know that there has been a global effort for enhancing the early initiation of ART. For enhancing the early initiation of RT, but still people are presenting with very low CD4 count and hence making them more susceptible to this inflammatory response. While the standard of care is that the ART is usually initiated after this 4 to 8 weeks of the MTB treatment. But studies have shown that in case of people whose CD4 count is less than 40, the early initiation of ART, that is within 2 weeks of TB treatment, have lead to decrease in the mortality of this people. So despite of this increased risk of this TB-IRS, the standard of care has been adopted of early initiation of ART in these patients. So in country where both this TB and HIV are endemic, they have an increase, they face an increased issue because of this TB-IRS. So the incidence of this TB-IRS is around 18%, while the mortality is around 2%. The high risk is seen in case of neurological TB, which is around 47%, where the mortality is also around 30%. The risk factors are the low pre-ART CD4 count, followed by the rapid rise after the ART initiation. The second risk factor is because of the short interval between the ATT and ART initiation. And third risk factor is because of the dissemination of TB to the extrapulmonary site. And fourth is because of the high HIV viral load. So this TB-IRS is of two types, paradoxical and unmasking. So this paradoxical, in case of paradoxical TB, these patients have already been diagnosed with TB and are initially on TB therapy, but after on initiation of ART, they develop this immune reconstitution syndrome. While in case of unmasking TB-IRS, these patients have subclinical infection, which was not diagnosed until the ART initiation, which will induce an inflammatory, induce an immune reconstitution leading to the TB-IRS. So coming to the pathogenesis, so this is the diagram showing the factor which causes the increases the predisposition to these patients for TB-IRS. So there is a low baseline CD4 count pre-ART. Then there is also short interval between the initiation of TB treatment as well as the ART. And third is because of the disseminated disease and also because of the high antigen burden. These all causes a strong uncoupling of innate and adaptive immunity leading to the state of predisposition. So these are the three immune arms which basically play a role in the development of the TB-IRS. So First is the innate immune activation, the first arm. Second is the adaptive immune activation, and third is the effector arm. So in case of the innate arm, first there is the recoupling of innate and adaptive immune system, leading to activation of monocyte and macrophages, and which leads to the inflammasome activation and production of interleukin-1 and interleukin-18. This will further lead to the membrane ruptures and release of antigenic content. So this, due to the increase of interleukin-1 and interleukin-18, there will be activation of pathogen-specific T cells, which will lead to production of lymphoid, pro-inflammatory cytokine and hypercytokinemia, and interferon by increasing production of interferon gamma, TNF-alpha and interleukin-6. Because of this accumulation of these all immune cells at the site of infection, this will lead to local tissue damage due to the neutrophil activation, which will secrete the metallic protein production, as well as which will lead to the matrix degeneration and release of antigenic content. Coming to the management of TB-IRS, so it is basically self-limiting, and only the short-term corticosteroid therapy is recommended. In case of mild form who are on ART, the observation is sufficient. In case of localized IRIs with ongoing ART, the local therapy such as minor surgical procedure for lymph node abscess drainage should be considered. While in most of the situations with ongoing ART, we should first recognize and manage the ongoing infection. The antimicrobial therapy should be given to reduce and eliminate the triggering pathogens. The temporary cessation of ART must be considered only if there is a life-threatening form of IRIs. Coming to the management strategy for TB-IRS, as we know that there is only one treatment, that is the prednisone treatment is available, that is also not FDA approved. So these are the proposed therapeutic interruption which aimed at various level of the pathogenesis, which can be considered for the treatment of the this disease, like the MCC 950, the doxycycline, the maraviroc, the statins. However, prevention is better than cure, so early HIV diagnosis as well as initiation of ART before CD4 count reaches less than 200 cells, and improving this screening of the opportunistic infection before the ART could help us in preventing this syndrome. Coming to the diagnosis of TB and in HIV co-infected person, so the diagnosis in case of TB HIV co-infection is challenging owing to the increase in the owing to the atypical clinical presentation, high proportion of smear negative diseases, as well as the extrapulmonary tuberculosis. The in case of resource limited countries, the microscopy is the mainstay of diagnosis. It is rapid, inexpensive. However, it is poor in sensitivity. The solid and liquid culture remain the gold standard for the diagnosis. They are slow and also they require considerable infrastructures. With the introduction of the nucleic acid amplification assays such as GeneXpert, RIMF assay, which has outperformed the smear microscopy. Because it is also because of the rapid turnaround time, the treatment could be initiated early. However, the sensitivity is less as compared to HIV infected person. This is because of the fact that any sputum based assay will have decreased efficiency in diagnosis in case of TB in case of HIV infected person compared to the non HIV infected person, because of the decrease in the CD4 count and atypical presentation. The next is the cellular immune response to infection, which is measured by the IGRA, that is the quantiferon TB gold in tube test, as well as the T-TB test. However, these are not able to distinguish between the latent infection from the active tuberculosis. Also, one new test which is under trial, phase 3 trial, that is the CTB test, is there, which has the cost effectiveness of the TST as well as the specificity of the IGRA testing. It basically contains the antigen, this culture filtrate protein 10 and the ES86 protein. So what are the coming to the advantage and disadvantage of various TB diagnostic modalities, which poses a challenge in diagnosis of this co-infection. So first is by the clinical sign and symptoms. The advantage are they are easy to identify and useful for screening. However, the disadvantage is that they are non-specific. In case of chest X-ray, these are available in the resource limiting setting, and the disadvantage is that there is a radiation exposure. In case of microscopy, these are the direct observation, and it confirms the diagnosis. However, disadvantage is that the paucity of this disease impact negatively on specificity. In case of culture, these are the gold standard diagnosis. However, they are lengthy process. Coming to the nucleic acid amplification tests such as GeneXpert, MTB, these are the point of care tests with rapid diagnosis, and it also identifies the rifampicin resistance. The only disadvantage is the respiratory sampling is difficult, as we know that because of the atypical presentation seen in the HIV-TB co-infected person. Coming to the latent tuberculosis TB infection. So, this latent tuberculosis infection is the persistent immune response due to the MTB antigen with no evidence of clinical manifestation TB. So as we know that globally there is no gold standard test for the latent tuberculosis infection. So the global data of latent TB infection is not known. However, it has been known that around almost 1/3 of population is being infected with TB, and in them around 5 to 10% progresses to active TB during their lifetime, usually within 5 years of exposure. So the prevention of active TB by treatment of LTBI is the main component of the WHO Stop TB therapy. So according to this WHO, the adult and adolescents living with the HIV, they should who are unlikely to have active TB should receive TB preventive treatment. Also, the infant aged less than 12 months who are with HIV, who are in contact with person with TB, and after it is found that there is no active TB, they must be given preventive treatment. Similarly, all children with HIV who have been successfully completed their treatment of TB should also receive the TB preventive treatment. Also, the pregnant woman should also receive the TB preventive treatment. So these are the algorithms which are used for screening the adults and adolescents living with the HIV for TB. So in case of adults and adolescents living with HIV, these 4 symptoms are screened: current cough, fever, weight loss, and night. And if it is not present, then we have to access for the contraindication to preventive treatment. The contraindication for preventing treatment are the active hepatitis, acute or chronic, or active hepatitis, or a patient is heavy alcoholic, or patient is alcoholic, and if there is no contraindication present, then the preventive treatment is started. And if there is contraindication to this preventive treatment, then we have to differ from the preventive treatment, and we have to screen this patient regularly for the presence of TB at their follow-up. If these symptoms are present, we have to investigate for TB and other disease. If other diagnosis is found, then we have to give appropriate treatment for that diagnosis. If it is not TB, then we have to follow up these patients and consider preventive treatment. In case of TB, we have to treat for the tuberculosis infection. So this is the algorithm for similar algorithm for the screening of children less than 1 year of age. Now coming to the testing for the latent tuberculosis infection, we know that the test available are the tuberculin skin test or the IGRA. So WHO doesn't recommend any of these. We can use, and WHO says that we can use any of these tests depending on the availability as well as the affordability. The patient living with HIV who have been found positive with this latent TB infection, they are found to benefit more from the preventive treatment than those who have tested negative for the latent tuberculosis infection. The LTBI for TST or IGRA is not a requirement for initiating the preventive treatment, so people can be given without testing also. So these are the treatment regimen. Most commonly, the 6-month isoniazid, daily isoniazid monotherapy is followed both for children and adult. Second is the 4-month daily rifampicin treatment, which is mainly used to avoid the risk of hepatitis. Then there is a 3 month of daily rifampicin plus isoniazid therapy. Then there is 3 months of rifampicin plus isoniazid weekly. Then there is 1 month of rifampicin plus isoniazid daily. Then there is a 6 month of levofloxacin daily which is used for preventive treatment for the MDR-TB. So coming to the isoniazid preventive therapy, so the benefit is that it prevents the incidence and relapse of the TB. All the adolescents who have screened negative for the TB are eligible, as well also the pregnant women. The contraindication is the presence of active TB or active hepatitis, or the signs and symptoms of peripheral neuropathy is there. The dose is 30 mg of isoniazid with pyridoxine 50 mg. So what happens if the patient on IPT develops TB during the IPT treatment? So in that case, we have to stop IPT and start ATT, and the drug susceptibility testing is also must. The patient who are previously treated for TB, they should also be given this IPT treatment. So this is the study which shows the benefit of the isoniazid preventive therapy in TB incidence and associated risk factor among the HIV patient. So they mainly this was the retrospective study done from the year 2001 to 2014, and it shows that these isoniazid preventive therapy was effective in reducing the treatment incidence among the HIV patient. Coming to the management of TB-HIV co-infection. So the TB-HIV co-infection management is difficult because of the drug-drug interaction, which adds complexity to both the TB cure as well as the HIV suppression. The treatment success rate depend upon the by maintaining the good adherence, preventing the drug resistant, by maintaining the therapeutic drug level, as well as the avoiding the adverse effects. So in case of drug susceptible TB, that the standard 6-month therapy regimen is being followed with 2 months of intensive phase and 4 months of continuation phase. We can see that the most common drug which shows the drug interaction is the rifampicin with the ARV, especially the protease inhibitors. In case of drugs resistant TB, which is the major since we know that the TB is the major cause of mortality, this drug resistant TB this causes an increase in the failure rate of TB treatment. So the TB-HIV co-infection also enhances the risk of harboring, acquiring the multi-drug as well as the extensively drug-resistant TB strain. It has been shown that the HIV positive cases have 24% higher risk of MDR-TB compared to the HIV negative one. The risk factor for this drug resistant is the because of the drug malabsorption, or because of the reactivation of infection, or because of the direct contact with the drug resistant TB case, or because of some common risk factors such as intravenous drug abuse, imprisonment, etc. So this is the 2019 RNTPC guidelines, which shows how the patient with living with HIV should be diagnosed. So the RNTCP, the nucleic acid amplification test should be done for these patients, for a patient. And in this, if there is rifampicin resistant is detected, then first line, second line LPA should be done along with the liquid culture DST. If there is presence of non-DST based criteria or resistant to any levofloxacin, moxifloxacin, kanamycin, capreomycin, or amikacin, etc., or any mutation is detected. If it is not detected, then the shorter MDR TB regimen should be given. If it is detected, then all oral longer MDR TB regimen should be given. If it is unknown, then history of use of more than 1 month or intolerance to moxifloxacin or kanamycin is there. So then we have to, if it is there, then we have to give oral longer MDR TB regimen. If it is not there, then we have to give shorter MDR TB regimen. While in case if rifampicin resistant is not detected, then we have to do first line drug line probe assay, and for the detection of isoniazid as isoniazid, and if isoniazid resistant is detected, then we have to go for second line probe assay as well as the liquid culture DST, and all oral drug resistant TB regimen should be given, and it can be modified according to the requirement. And if it is isoniazid resistant is not detected, then we have to continue the first line treatment. So this is in 2019 the RNTP has reduced the number of standard regimen for drug resistant TB from 13 to 3. Now for the isoniazid mono poly drug resistant TB, all oral isoniazid mono-poly drug-resistant TB regimen is followed, which include 6 months of levofloxacin, rifampicin, ethambutol, and pyrazinamide. In case of rifampicin-resistant MDR-TB, shorter regimen as well as all oral longer regimen is given. So coming to the management of HIV-TB co-infected persons. So the general principle for management of these patients is first by doing the intensified case finding using the 4-symptom complex. Second is these patients with active TB diagnosed with HIV. The first priority is to start the TB treatment in accordance with the RNTCP guideline. Third is that all HIV-TB co-infected persons are to be initiated on ART regardless of the CD4 T cell count. And fourth is the cotrimoxazole prophylaxis should be given to all HIV-TB patients to reduce the cases of bacterial pneumonia as well as the many parasitic infections such as the pneumocystic infection as well as the nocardiosis as well as the isosporiasis. So this is the algorithm which is being followed for the intensive case finding in the ART syndrome by using the 4-symptom complex, that is current cough, fever, weight loss, night weight. In case of children, there should also be a history of contact with the TB case. So coming to the ART initiation in patient living with TB co-infection. So all patients diagnosed with the active TB are to be initiated of ART regardless of the CD4 count. The ART may need to be started later, keeping in mind of the pill burden, time needed. So these are the disadvantages, that there is a pill burden or there is a drug interaction and toxicity which can lead to the IRIs. So in case of HIV-TB co-infected, ART should be started regardless of the CD4 count, and the first the ATT should be started and ART should be initiated as soon as the TB treatment is being tolerated, that is between 2 weeks to 2 months. However, in case of patient coming with CD4 count less than 50, ART is initiated early as studies have shown decreased mortality in this patient. Next, the recommendation if TB is diagnosed in the patient who have already been receiving ART, so there should be modification of ART. This is to prevent the drug-drug interactions. So if they are on NRTI or NNRTI regimen, then there is no need of any change. While if there is on nevirapine based regimen, as it is known to interact with the rifampicin, this nevirapine should be substituted with the efavirenz till the completion of ATT. In case of protease inhibitor based regimen, the rifampicin should be substituted with rifabutin, as it has better T life and it is been less potent enzyme inducer compared to the rifampicin. In case of protease inhibitor based regimen in child, there should be super boosting of lopinavir with ritonavir is recommended. In case of raltegravir integrase inhibitor containing regimen, we should substitute rifampicin with the rifabutin because of the drug-drug interaction. So, if there is a patient who is presenting with active TB within less month of initiation of ART, then we should not consider it as a failure of treatment. But if the patient is presenting after more than 6 months of initiation of ART, then the diagnosis of ART failure should be done based on the CD4 T cell count and the viral load. Coming to the different strategies for the prevention of linked epidemic of HIV-TB, so WHO has endorsed a collaborative activity to reduce the joint burden of TB and HIV co-infection. These activities constitute the backbone of TB-HIV collaborative adopted under the Stop TB strategies. So earlier it was only 3 I's, now they have included 3 more components. First is the intensified case finding, then the isoniazid preventive therapy, then the infection control, then the initiation of ART, integration of TB-HIV as well as involvement of the community. So there should be a standard protocol to diagnose the pulmonary and extrapulmonary TB. There should be prompt introduction of ART in case of MDR, XDR, TB as soon as the anti-TB drugs are tolerated. There should be empirical therapy with second-line anti-TB drug in patients who came from the areas of MDR or XDR prevalence area, and the cotrimoxazole prevention therapy should also be started. The treatment, there should be a treatment supervision by the specialized team. There should be implementation of nutritional and the socio-economic support. There should be effective infection control to prevent the transmission, and there should be promotion of the managerial activity. So this is the WHO policy on collaborative TB-HIV activity. So WHO recommends establishing and strengthening the mechanism for delivering the integrated TB-HIV services. It also recommends reducing the burden of TB in people living with HIV by an early initiation of antiretroviral therapy by using the 3 I's. And it also reduces the burden of HIV in patients with presumptive and diagnosed TB by providing HIV testing and counseling to the patient with presumptive and diagnosed TB, and providing antiretroviral therapy for TB patient living with the HIV. Thank you. Any questions? Thank you.